Well, the biggest challenges that we face today is that we still don't have a cure. The good news is we finally have many treatments that we can offer our patients, and most of these treatments result in improvement in the patient's condition. But the primary challenge is trying to find something that will reverse the disease and make it go away. The other challenge that we face now is that we have so many types of medications, it's hard to figure out which medication is best for which patient. And deciding which patient will respond to which one of the medications that are available is going to be one of the larger challenges we have going forward. There have been quite a few recent developments in PAH therapy, but I think without question the best news is the fact that we have so many agents now that can attack the disease from a variety of different angles. There are presently 5 different categories of drugs, and many of those categories have multiple drugs within each category. And so as a result, not only do we have different ways of approaching the disease, but we have different treatment options to offer the patient in terms of what type of therapy they have, whether it's inhaled or oral or intravenous, and different combinations that we can use to try to get to make the patient as good as possible. So the recent studies have demonstrated fairly nicely, I think, that using upfront combination therapy results in an improvement that we can't get with monotherapy alone. It's unclear at this point why that happens. It may be that the combination of 2 drugs together is stronger than either drug alone, or it may simply be that by using 2 drugs we're more likely to find the right agent for the right patient. So we think the use of 2 drugs together is probably more beneficial. But going forward, it would be nice to find a way to see if there is a way of telling whether or not a patient's going to respond to one drug, preferably over another. And the reason this becomes important is because we're just beginning to entertain the idea that if 2 drugs are more beneficial than one, then perhaps 3 or 4 are more beneficial than 2 or 3. And at some point we have to get down to focusing on which drug is best for which patient. So oral anticoagulation therapy has never been formally studied in pulmonary arterial hypertension in a way that we can really determine whether or not there's an outcome benefit. In some cases we think there is, and certainly for people that have chronic thromboembolic pulmonary hypertension, long-term anticoagulation with an oral agent is absolutely imperative. In other cases it becomes less clear. And as a result, frequently the way that we'll decide about this is that if the patient doesn't have any contraindications to anticoagulation, it's something to consider. But I think for right now it needs to be on a case-by-case basis. Yeah, so I think the primary gap in knowledge at this point is trying to figure out which patients are most likely to respond to which drugs. There are numerous abnormalities and signal pathways throughout the pulmonary vascular circulation, and these drugs attack different members of those pathways. And as we learn more about the disease and how the disease is caused, we may be better able to tell which drug is going to be more beneficial for which patient. And that's probably the major challenge in trying to do more research in that area.